Okay, good morning. I was about to say afternoon, but good morning, everyone. Call to order the statewide substance use response working groups treatment and recovery subcommittee meeting. So glad to see everyone today. Excited to have our discussion today. Um, on that note, I will turn it back over to Kim to do roll call to establish quorum.
Thank you, Chair. So I will call out names, and if folks could please let me know if you are present. Steve Shell,
Here.
thank you. Giuseppe Mandel,
Present.
thank you. Assembly Member Edgeworth, okay. I don't see the Assembly Member, but we'll come back to that in a moment. Up next is Member Dave Breaks. All right. I don't see Dave as present. Dave, if you're present, could you let us know? Okay. And then also Dr. Partita Corona, who I believe is on. Thank you. So at this point, Chair Shell, I believe we only have 3 members present, which does not give us a quorum.
Okay, thank you, Kim. So on that note, go ahead, Kim.
I was just going to say, let me do one more check and just confirm that neither Assembly Member Edgeworth nor Dave Briggs are on. And let me just do a check of the other members who told us they could not attend. Stephanie Cook, are you on? All right, and Assembly Member Golding. Okay, so with that, it looks like 4 members are not present and 3 members are present.
Okay, thank you, Kim. So due to not having quorum, we can continue with our meeting, but we won't be able to take any action on any items of the agenda. So we can certainly have a discussion with the 3 members who are present, which I don't think is a bad thing. I think we can certainly go through and talk about some of these recommendations, especially for Dr. Perdita Corona and Vice Chair Mandel. I think that might be helpful. And then hopefully some of our other members will join us and give us that quorum in case we do get to the point that we'll need to take action on any item. Okay, so
Chair
yes,
Shell,
Kim.
sorry, Chair, if I could just do one check very quickly. Dave Briggs, did you just join us? Did Member Briggs just join us?
Yes.
Perfect. Okay, so with that, I believe we now have 4 members. We have Steve Shell, Giuseppe Mandel, Dave Briggs, and Dr. Partita Corona all on. And so I believe that gives us quorum with 4 out of 7 members.
Okay, great. Thank you, Kim. Okay, yes, as Kim said, we do now have quorum, so that is very good in case we do need to take any action on any item on the agenda. So proceeding with our agenda, we'll move on to item number 2, which is public comment. This is for discussion only, and I will turn it back over to Kim to walk us through that process.
Thank you. All right, so as you can see on the screen, public comment will be received via Zoom. We ask you to please raise your hand or unmute yourself when asked for public comment. Public comment is limited to 3 minutes per person. This is a period devoted to comments by the public, and if any, and discussion of those comments, no action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken. If you are dialing in from a telephone, please dial 669-900-6833. When prompted, you'll enter the meeting ID of 865-8016-1096, and please press *6 so that we can prompt you to unmute. And we do ask that members of the public refrain from commenting outside the designated public comment periods unless specifically called upon by the chair. Okay. I do not see any hands raised. So I do not believe that we have public comment.
Okay. Thank you, Kim. That will conclude public comment. We will move on to item number 3 on our agenda. This is a review and approval of our minutes from our subcommittee meeting held on November 18th, 2025. Hopefully, our subcommittee members have had a chance to review the minutes, and if so, we can entertain a motion to approve. So if anyone on our subcommittee who has reviewed the minutes would like to make a motion to approve, we can entertain that now.
Motion to approve.
Oh, thank you, Dr. Perdita Corona. Do we have a second?
Giuseppe Mandel, second.
Thank you, Giuseppe. Any discussion regarding the minutes? Okay, hearing none. All those in favor, please say aye.
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 Any opposed? Okay, motion carries unanimously. Thank you. Moving on to item number 4. This is for discussion only. This is our 2026 timeline reorientation and a review of our recommendations submission process. So in the next slide, you'll see some dates. Hopefully all of these dates are on the calendars of our subcommittee members. If not, please let the SEI team know and they'll make sure that you receive the link to all of these meetings. But these dates are very critical. You'll hear in just a moment from Kim that we have a very tight timeline for this year. So I'm going to now turn it over to Kim to go through what each of these dates actually mean and why it's so critical for all of us at this point. So Kim, back to you.
Thank you. Thank you. So as you can see on the next slide, this is the overview of the subcommittee meeting timeline through the rest of this year. The big piece to note here is that June of 26 is when final recommendations for this reporting cycle will need to be completed. And so we are going to toggle back and forth between 2 slides for a moment here just to kind of confirm what that looks like, because the primary takeaway of that is that March is really the last subcommittee meeting in which discussing preliminary recommendations for inclusion in this year's reporting cycle would be ideal. And so that could include some subject matter expert presentations as well as sort of final discussion of preliminary recommendations, because at your May subcommittee meeting, that's when you'll be asked to finalize and rank your preliminary recommendations for full review by the SURG. So what the actual cadence of this looks like is, if you want to go to the next slide, Mary, thank you, is you can see here that there are, in April, we'll have our next full SURG. So at today's meeting and your March subcommittee meeting are where you'll be getting your final slate of preliminary recommendations. Those will be provided to the full committee, the full SURG, at their April meeting. And then any feedback they have will come back to you all for consideration at your May subcommittee meeting. They will then, perfect, thank you. Sorry, I apologize for the toggling back and forth. We couldn't really get it all on one slide. Those recommendations will then go back. Those final ranked recommendations from each subcommittee will go to the full SURG in June, at which point they'll give any final feedback, and your June meeting would be the opportunity to review and incorporate any of that feedback. So it's a bit of an iterative process over the next few months, but I think the primary takeaway is any preliminary recommendations that you'd like included in this reporting cycle ideally would be put in front of the group by no later than the March meeting. That doesn't mean that recommendations that come up along the way can't continue to be considered. They might just not make it into this reporting cycle. So that's the piece to note, is that if something comes up today or in March or even at your May meeting and there isn't enough time to get it in this annual report cycle, it will still be kept on the slate for future consideration.
Okay, Kim, could you toggle back to the one that actually shows the dates? Just real quick. Thank
Yes.
you. Okay, we're good.
Perfect.
Okay, that all makes sense to me. Everyone else on the same page?
Yeah, Kim, I wanted to add just to say that for our newest members on the subcommittee, this probably feels like a very tight timeline, but it's because we're on the tail end of this year-long process. And so I think going forward, those of you that are new on the subcommittee won't feel like it's such a tight timeline. I think it's because you're now joining us at this point in this juncture, and I think that's probably why it's feeling like a very tight timeline. So just wanted to get that out there.
Yeah, thanks, Steve. That makes sense to me. It's, obviously it's my first meeting, so I'm just trying to kind of get up to speed, which is why I didn't make any recommendations because I don't really just trying to get my feet underneath me. So, but no, it sounds like a good plan. Thank you.
Yeah, thank you, Dave.
And then Giuseppe Mandel for the record also, now newer to the subcommittee and then newer to vice chair, which please give me grace. This is all brand new to me in this treatment subcommittee. So I would appreciate any coaching along the way if allowed and legal to do so to get recommendations in.
Oh, absolutely, Giuseppe. We're here to help and support any way that we can. And as Kim noted, we still have a little bit of time. I mean, yes, it is a very tight timeline, but if there are any ideas for recommendations, we'll get into that more in a few minutes, but we certainly have the next couple of months to be able to explore, any recommendations that any of you may want us to consider.
There are Dr. Partita Corona, by the way. There are a few recommendations that we discussed at SNAP that we're putting forth through Nevada Society of Addiction Medicine as well. Basically, they're about prior authorizations and hopefully eliminating the requirement for prior authorizations for buprenorphine and basically medication-assisted treatment, simply because of the very nature of addiction and the very narrow window of opportunity that we have to treat. Prior authorizations are basically handcuffs to treatment. That and we're also making a recommendation that the Medicaid should refrain from stipulating particular dosages because they're also limiting dosages to 16 milligrams a day for folks that are basically seen as maintenance. But I've seen that enforced actually on the second month of treatment. And that becomes a huge obstacle, especially with patients that are coming off of fentanyl, because those patients actually usually require about 24 milligrams to maintain in their recovery. So they shouldn't be stipulating the dosage. That should be a decision to be made with the physician or the provider. It doesn't make any sense. We don't make any stipulations like that for OxyContin, which is what kind of got us into this mess. I don't see why we're doing it on a medication that's actually used for medication-assisted treatment.
Yeah, Dr. Partita Corona, thank you so much for bringing that up. We're going to have a section on our agenda in just a few minutes where we can dive further into that. So I really appreciate you bringing that up. Thank you.
All right.
Okay, Kim, anything else on this particular agenda item?
Just to mention to subcommittee members the recommendation submission process. So there's a few ways that recommendations can be brought up and workshopped. And then ideally, what we ask the subcommittee members to do is to submit their recommendations using the survey link that we provide. I did send that out recently, so folks should have that. If you don't have access to that, please let me know, and I can also just resend it after this meeting if that's helpful. We ask that members complete each section of the survey to the best of your ability. There are required fields in that Survey Monkey that we ask you to complete. If you don't have information for a particular section just yet, we don't want that to hold you up from getting the other information in. Feel free to put in an asterisk or any kind of entry that will register in the system, so it'll let you keep moving forward. Or you can add a note that says, I have a question about this. You know, you can use that survey in that way as well. So we don't want it to feel like you have to fill out every single section every time. What we will note is that everything that is provided in that, for the most part, unless it's refined along the way, is included in your annual report. So that is the backup for the recommendations. And so we will work with you if we have any questions on that to make sure that we're documenting it correctly in the report. Those recommendations would then be presented to members at the next regularly scheduled subcommittee member, and we can assist you with gathering information or connecting with subject matter experts. So feel free to reach out to us as well directly if you have any questions about this process. I know it's a new process for several of the folks on the call today, so we don't want you to at all feel limited by that. So please reach out if you have questions or if there's any supports the SEI team can provide to you. And I think that's it on the submission process, unless there's any questions.
Okay. Oh, yes, Dr. Perdita Corona.
Yeah. When was that survey sent out? I just want to make sure that I have it.
Yeah, I sent it out, I think, a week or so ago, but I can resend it following this meeting.
Yeah, if you would, please.
Just to bring it top of inbox. Absolutely, yeah. Happy to.
Thank you.
Okay, thank you so much for that overview, Kim. Okay, we will move on to item number 5 on our agenda. This is for possible action. This is a discussion of our proposed treatment and recovery subcommittee recommendations. We do have 3 recommendations currently on the table that we have been exploring for a while now. One of which you'll hear in just a moment is our newest of the 3 that we are beginning to explore. But the first 2 we've had on the table for a while now and have been exploring those. And as Kim said a few minutes ago, those would all be part of the overall recommendations we'll consider at our May meeting to move forward to the full SURG in June. So as we said, you know, we've got a little bit of time to vet these a little more if we need to, or to consider new recommendations as well. So the first one, just to refresh some of our existing subcommittee members and our newest subcommittee members. The first recommendation here was submitted by Chelsea Cheatham in August of 2025. She has now moved over to our prevention subcommittee. And so Stephanie Cook, who is one of our fellow treatment and recovery subcommittee members, she has volunteered to co-sponsor this and carry this forward, although she's not here today. But we thank Stephanie for agreeing to co-sponsor this. We have had lots of discussion around this particular recommendation and had a team from Connecticut actually present to us a few minutes ago on the assessment and studies that they have done. But this is a retrospective assessment and or prospective study would be conducted to assess the outcomes of patients following discharge from detox and examine mortality and overdose. I know Chelsea felt strongly that we have not had enough of this data in our state like a lot of other states have. And so Connecticut has really been a trailblazer in this area. And so we brought them in to go through all of the data that they have collected and analyzed through the years. And it was very helpful. And there's information that we received from that study that we could certainly have the SEI team send out to our newest members if you're interested in seeing some of that. But regarding this particular recommendation, we wanted to hear from you all today if there's any further discussion on this one, any other edits that anybody might want to recommend be made to this recommendation, and so forth.
Out of curiosity, what was the length of the study that how far back and how far forward are they planning on looking at for post-detox?
That's a very good question, Dr. Perdita Corona. I don't think we've got to that point, Kim, if I remember correctly. I don't think we had some discussions around it, but nothing definitive. So certainly open to your thoughts on that, Dr. Perdita Corona, and what you think we might need to look at or change here.
Well, I've always taken the approach that when it comes to recovery, it's not about a year out, it's about making sure that they die in their 80s of something else. You know, that to
Yeah.
me is true success rather than just sobriety for a year. Um, given that, I think we should look at like a probably 3 years out, I think would be reasonable post detox as far as looking at a retrospective study, because that would also probably encompass a lot of relapses and and I think it would be good to compare the amount of relapses that happened while someone was on, you know, continued therapy, continued MAT, continued involvement in 12-step programs. Basically, you know, the biopsychosocial model, how many of those legs were at work when we look at the 3 years out, you know? Does that make sense?
Yes, it does. I'm glad you're bringing that up. Does anyone else have any thoughts about that?
Giuseppe Mandel for the record. Yeah, I do as well, man. I think that's a really important study, but I think we need to highlight and add into to make sure we're getting where we're getting the study numbers from. I know, and it's an issue, and it's not an easy issue to solve. I'm well aware of that working in treatment of pulling numbers not just from Medicaid population, because I think that's important. And a lot of the studies I see only pull from the Medicaid population. And why I highlight that is because in the commercially insured population, generally it's not just detox, it's residential treatment that's covered also through insurance. And I'd love to see, and I don't know, that's a difficult problem to solve, right, with HIPAA and stuff, but love to see the numbers of say, and other states do it, but the numbers of just detox and then an IOP, PHP, and the success rate going on throughout the years versus a detox residential treatment and then ongoing PHP, kind of a 90-day continuum, and what the different results are for that. And I'll highlight why that is important, because in the ever-ending struggle with insurance, and Dr. Corona can kind of contest this with authorizations, even in a different round. Authorizations on our part is we've just noticed so much success with, say, Henderson Drug Courts program, where when insurance, if they're in custody for 2 weeks, insurance doesn't authorize it. So Henderson Courts, they have a separate fund where they can come in and they can pay for treatment to ensure that they get treatment even if insurance doesn't authorize, and it's a longer term treatment because the courts know it's more successful. And so analyzing those results will help us later on down the line. And I know it's not going to happen overnight, but later on down the line for 5, 6 years down the road, it'll help us to where we can actually see like which treatment is best, and where to put fundings towards in the future, whether that be just a detox to PHP, just to MAT, or a detox residential PHP. Just really important numbers. And guys, I know it's a tough task and it's a lot of work, and I'm new to this, but just kind of trying to highlight the experience of my lived experience as well of the spin dry detox and going right back out after detox versus going into a detox residential and then sustaining recovery through 90-day program. And I mean, 3 years, sometimes maybe we want to go out even longer than 3 years if participants are willing. I mean, I've got a brother that died after 9 years because he went back out after 9 years, so a full spectrum of study of what successes, what that patient stops doing that leads to the relapse and death. I mean, I've got a ton of ideas. I know that's a lot of information to swallow right now, but big
Well,
highlights.
I know this much. 7 years out is beyond 7 years out. It's going to be tough simply because a lot of medical records get done away with after a certain amount of time. So it'll be harder to cobble that together if we're talking about a retrospective study. But perspective, I'm with you there, Giuseppe. The longer the better. And I think you're right on point as far as looking at whether court mandated treatment had a different outcome. Because it is important to figure that part into the equation, because they are unlike any other field of medicine. They are very much a factor in how we're able to provide treatment, because someone ends up in jail or in prison, then it's a whole nother ball of wax as far as how we get them to some sort of treatment. And it can be more of a disruptive rather than a beneficial process there, especially if there is no MAT or any other form of treatment in the facility.
Yeah, Dr. Cronin, I mean, just like Mandel, for the record, I second that. And the commercially insured population, which I know would have to be voluntary people to go into the study, but very important too, because it's a different kind of treatment. It's more long-term, and there is a lot of success in that model. And in a lot of the studies I see, we're just pulling from the Medicaid population, and we can figure out a way to get them before they get to that side, and end up on Medicaid. I mean, I work with a lot of the unions and, a lot of the courts and stuff. And I mean, we have a lot of success getting there way before they get on Medicaid. So I just love to see the study, because I think it'd be very beneficial, especially for the future.
So Giuseppe and Dr. Corona, in terms of the recommendation itself, can you share what you think our edits need to be here so that SCI can note that?
Well,
Go ahead, Dr. Cronin.
so I say, we split the baby here, go 5 years. What do you think, Giuseppe?
Yeah, I mean, 5 years is that's a good model.
Yeah, if it can be done. So 5-year retrospective, and include questions of whether they're involved in, AA meetings, whether they're involved in counseling, in particular cognitive behavioral therapy, and at what points they're involved with that counseling, and whether they're received MAT, and whether they continue to receive MAT throughout their period of recovery. Because
yeah, and if you could add in there, and I know it's voluntary, I don't know how you get the data, but if you could volunteer in there, whether it was a Medicaid population, or whether it was a commercially insured or self-paid population, and then whether it would be a court participant program, where it would be a drug court participant program as well, drug court or alcohol, DUI court, whatever.
Now, as far as insurance, you're going to see a lot of folks being bounced in and out of insurance, simply because some people will be insured through Medicaid, and then get hired somewhere, and then all of a sudden they're commercial. So that's going to you're going to have a mix there.
I guess at the point of treatment, right? At the initial point, at the start, at the point of treatment, was it Medicaid, or were they voluntary, or forced through work, or the courts?
Yeah.
And whether commercial or Medicaid, just because it's a different treatment. Medicaid most of the time doesn't really pay for the full residential spectrum, where commercial does, and so be important to see where the difference of success is on it.
Yeah, no, that's fair.
Does that help, Mr. Shaw?
Yes, no, that's very helpful. Thank you. And I do agree with the 5 years. Dave, any thoughts on that? Are you in agreement as well?
Yes, that makes sense. I think it was a good point. 7 years is, the medical record type of thing, so that gets difficult. And I guess the further out we go, the more people are not able to track whether they've moved to another state, or or just, decide they don't want to participate anymore. You can't, or, they're living on the streets and they're more difficult to find. I mean, those are obviously obstacles that can be, addressed along the way, or, those are outliers in those studies. But yeah, 5 years seems like a kind of happy medium there.
Correct.
Yeah, I mean, you've got somebody like myself in the meeting that would be happily submit all my medical records and everything to you, and I've got well over 5 years. That's sitting right in the meeting. So I'm sure there's a lot of other people that would do it as well.
One other thing I wanted to mention that we have found helpful through my years on the surge is being able to identify a funding source for whatever recommendation we're making. And so I wanted to mention that today. I don't know if we'd like to include that we're recommending that general funds be set aside for this study and or funds from the Fund for Resilient Nevada utilized for this study, but it probably would behoove us to think about including a funding source and as part of our recommendation too. So just wanted to put that out there. See if
And
anybody had.
Mr. Shell, too, yeah, I mean, if you could, because I know sometimes there's restrictions with the government, which will come into one of my recommendations later on with the drug court programs. But like to include that if the availability of private funding is out there as well, that we be allowed to accept it for the study. I know in drug court, there's handcuffs and stuff. We're trying to figure that thing out with Henderson right now, where we can accept private funding and still be allowed to use it, where it's a nonprofit there's a lot of red tape with it. So I don't know, anything to alleviate red tape that'll help.
Out of curiosity, have we thought of using the fellowship to work with this study?
That has not been brought up, Dr. Cronin, but that's a great idea.
Yeah, I mean, they have to do some sort of research project anyway, and if this were like an ongoing study that they could be involved in, it would help elevate the fellowship program that we have, plus provide them with a means to do it, because it's very like any other new fellowship program, cash strapped and resource poor, but they do have fellows, which is what we would need to do this anyway. That and maybe would UNLV have like the School of Public Health there? Could any of them run with it as well?
Possibly, yes. Even with the fellowship program, would there need to be an infusion of money into the fellowship program, or is this something they could automatically take on with their existing resources?
I don't think with their current resources they could, but I think
Okay.
if we incorporated at least some resources there, they would probably bite, I would guess. I would have to talk to Dr. Strom. She's the director there. And I'm sure she would have to fly it up the flagpole with HCA, but it's a potential. And like I said, I think it would be a nice feather in the cap for the fellowship as well.
I like involving the fellowship. I like involving the higher education in this because now we've got the fellowship program launching in Northern Nevada.
Yeah.
So I think that would be very helpful between UNR and UNLV. And that could be part of our implementation process with this. Maybe we're recommending that general funds and or FRN funds be used for this, this assessment and study, and then allocated to the parties you just mentioned. Maybe
Yeah,
that's the way we
it would be a
try.
great collaboration between the fellowships, actually.
Yeah,
Yes.
you also have Dr. Edgeworth who just texted me. She apologizes for not being around, but I mean, keep in mind she's over at Touro University as well. Not only is
Oh,
she a
that's great.
politician,
Yeah, that's good to
yeah,
know too,
and
Giuseppe. Thank you.
she's subcommittee meeting.
So yeah, I think we have maybe some people that will bite with it, but it's a matter I think it would be good to at least get some general funds for it, especially because if it's going to be a collaboration between uh, different entities, there's always going to be a, well, who's going to pay for this question? And then,
Exactly.
yeah. So that kind of removes that whole, pardon my French, but pissing contest out of the equation.
Yeah,
And if
you're
we're talking
exactly right, Dr.
colleges,
Cronin. Go ahead, Giuseppe.
if we were talking colleges too, man, and college students, I mean, never underestimate the fraternities in fundraising and develop into some type of fellowship competition between UNR and UNLV to come up with whoever gets the best funding for their study.
Good point, Giuseppe. Kim, are you taking all this in? Are you getting? I know we've discussed a lot of changes to the recommendation, which have all been great. Or do you need time to workshop this a little bit, Kim, and bring it back to our next meeting? Or
That's what I was going to ask the group if they're comfortable with that. What we can do is review our notes and the recording, take our best first pass at incorporating all the feedback from the members that are present, and then provide both the original and a possibly updated version at the March meeting for hopefully the larger group to review and refine or finalize. Would that be acceptable to the group?
Yeah.
Okay.
that sounds good. Okay, so any other discussion regarding this recommendation before we move on to number 2? Okay, thank you. Okay, so recommendation number 2. This is one that I had submitted last summer. I have felt very strongly for years that hospitals needed to be more motivated to have peer recovery support teams in the ER. I know from my own personal experience, when I've had a team in the ER, it was grant funded. The grant ended up running out, and so the health system was not able to continue to sustain that program, and so therefore it went away. And so I really feel that the state needs to be figuring out a way to help incentivize hospitals to have these teams in place. It's great that Medicaid is covering peer support now, but we have lots of other payers that do not reimburse for peer recovery support. And then we also have the uninsured population as well. And so a lot of hospitals are very reluctant to stand up these teams, knowing that they're not going to be able to reimburse or recoup, their cost for the team. One thing and this is one that we've been discussing for quite a while in our subcommittee. One edit we have made here is adding the funding source here. As I just said about our last recommendation that we discussed, we added here that we could recommend that general funds be made available to hospitals, or we could encourage hospitals to apply for FRN dollars. And I know there are a couple of health systems that are in the process of doing that. But I think if the state took a more active approach in that, we might see more hospitals willing to go down that path. So just wanted to put that out there today to see if any of you all, especially our newest members, have any recommendations for this one, any edits that we might want to make.
Yeah. Hold one second.
Giuseppe Mandel, for the record, well, Dr. Corona is looking at
Yes, Giuseppe.
I mean, I can tell you, like, Valley Health System is doing it right now. They're scratching the surface with it, and I work with the peer recovery support specialist in my job, and I know that it's a lot of positive feedback from it. So I don't know what the answer is if you get champions of nurses and doctors in there to help advocate for that.
Yeah, I think that's what it would certainly take,
Yeah.
Giuseppe. I think if the state took a stronger stand on this and helped motivate hospitals to go down that path, I think you're right. You would be hearing a lot of nurses and physicians advocating for this.
Yeah.
I know when I had a team in place in the past, we were able to see great results from it. And I've been hearing that the Valley system is also seeing great results as well in Southern Nevada. So I think studies show that the teams do work in getting people connected to resources.
They do, and it's also, I don't know if a way to motivation would be like a workforce development program for them too, because eventually some of those peers, like I recruited one of the peers on our team at Alia Health Group, right? So work development to get him, starting in that nonprofit, the lower aid peer recovery to job development right into, working with the big boys with us. That could be appealing to them too if there's an education money or something with it. They're just trying to think outside the box to motivate the
Right.
hospitals.
One of the thoughts that I have had regarding peer recovery navigators in the hospital is this. Oftentimes, you see insurances sometimes take the initial role rather than hospitals. And if that were the case, I think it would be rather ineffectual. Because what happens in an ER is you kind of have to have someone that's embedded there rather than someone that goes to different hospitals. Because what will happen is there won't be all that much familiarity, and it's that rapport with the ER docs, and the fact that they know that they can call them in a matter of minutes. They're there to tend to the patient that will initiate that conversation regarding recovery. So it has to be folks that are actually embedded in the actual hospital rather than folks that are contracted through the insurance. Because if it's through the insurance, they're going to have one person that goes to 3 or 4 different hospitals, and it will, like I said, be ineffectual. Because of that reason. One of the other thoughts that I've had was the idea of an addiction service in hospital, or maybe throughout the different hospitals that are tied to these peer recovery navigators. Now that could work, but we would have to have enough folks that are in those hospitals that are and the delineation of privileges for those for that specialty in those hospitals. So that may take a while to happen. Are you guys familiar with delineation of privileges?
Yes.
Okay. Giuseppe, are you familiar with it or no?
No.
Okay. So basically, delineation of privileges in a hospital basically means that you are basically have a skill set to deliver a particular service to patients in that hospital. And because you have that specialized skill, you're viewed as a specialist rather than a hospitalist. So normally when you get admitted to a hospital, you have the hospitalist that runs the patient's care, but say they need hemodialysis. A call is made to nephrology, and nephrology comes in to write the hemodialysis orders. That is why that nephrologist can see the patient and give the orders for the dialysis and get reimbursed by the insurance, because otherwise they would be viewed as a hospitalist, and they only pay one hospitalist per day. So then you wouldn't have those specialized services included in that patient's care while they're hospitalized. So that's why you need delineation of privileges in the hospital for addiction, so that those services can be had as a specialty service. Now, one way that historically we've gone around it is by consulting psych, but psych is different. Psych is much different than addiction medicine. A lot of psychiatrists, quite frankly, avoid addiction like the plague. So they're not, excuse me, they're not particularly trained for handling addiction. So it's consulting the wrong service oftentimes. Now, there are some addiction specialists that are well versed in addiction, but I would argue that that's definitely the minority. So that's why the delineation of privileges. But if you had a consult service of addiction specialists that covered the entire valley, and you had then peer recovery navigators and maybe some CARN certified nurses working underneath them, that could work. And that way, these patients don't just get in front of a peer recovery navigator, but they get tied into a whole system of treatment. Does that make sense?
It does. It does. So what would that be? Would that be for like something like policy change to advocate to the state, or like would that be a whole different recommendation than right?
Well, I honestly think that in order for hospitals to get at resiliency funds or any other funds for addiction, I think they should at the very least have delineation of privileges drawn up for their hospitals to allow addiction to be seen as a specialty in the hospital. I don't see how you can. I don't see how you can provide a service without having the specialty to provide the service. Does that make sense?
It does, and I know that the Las Vegas Recovery Hospital just opened. Are you familiar with that?
Yes.
And
Yes.
is that so? Would they have that delineation?
I'm pretty
Delineation of
sure.
privileges?
I'm pretty sure that they would, but that shouldn't be one hospital. It should be
Agreed. Yeah.
throughout the valley that we have those services to render. It doesn't need to be one hospital dedicated to those services, because even if it were a stellar hospital, that means that whenever patients end up, at UMC with an overdose or the like, you don't even have someone that's addiction trained that can be accessed there. And that doesn't make much sense to me. That should be a service that should be available pretty much everywhere.
Well, I will say, Dr. Cronin, when I made this recommendation, it was to have an embedded team, just like you mentioned. So I'm glad you brought that up. And that's certainly a term that we could add to this recommendation, that it would be an embedded team. That's all I've ever envisioned, that this would be embedded. I don't think that it could work otherwise.
Yeah, but it'd have to be deeper than just a peer recovery navigator. And it doesn't have to cost them money as far as the rest of the team, but they have to allow the rest of the team to form. And the way they allow that is by writing up delineation of privileges and having them there available for, outside organizations to, like, let's say there's an addiction specialist that comes into town. Okay, he can apply for privileges as his specialty in Sunrise Hospital, and he can be part of the embedded team with the peer recovery navigator. But and that won't cost the hospital anything other than the paperwork to do the delineation of privileges. It's not really a big ask, but you have to get it through committee, and committee, works at the speed of glaciers. So but that's the key, is if we want those peer recovery navigators in there, that's great, but they got to have resources not just outside of the hospital, but inside the hospital as well.
So maybe, Dr. Cronin, what you're saying is just to expand on where it says hospital ER-based peer recovery support team, maybe expanding on that to include the physician and the peer recovery support specialist. Maybe are we thinking about expanding on what the team means? Or
so what I would do with this is I would make it a condition of, like, if they want access to those funds through those resiliency funds, they would have to have not just a way to get peer recovery navigators in the doors, but they would have to have delineation of privileges for both mid-levels and for addiction specialists. And what I mean by addiction specialists, I don't mean just a hospitalist that wants to do addiction. I'm talking about people that are actually certified or, have been grandfathered. They actually have addiction, uh, an addiction background in their training. And that way you have them. I would make the mid-levels have to have some sort of addiction training too. There's current certification, which is pretty darn inexpensive to obtain. Current certification is kind of like the board certification for addiction for nurse practitioners. But very seldom do you actually see people go for that, because a lot of these facilities are recruiting people that have absolutely no addiction backgrounds, and that's a problem, because when they get in there, their training was how to treat diabetes and hypertension, not how to treat addiction, and so that's why we should expect a certain level of training in both the physician and the mid-level, but there should be a delineation of privileges that allots for that level of training, but that opens the door for them to work in the hospital under their specialty, rather than as just plain old provider.
I think that's great, Dr. Cronin. I like that being a stipulation that a hospital would need to have those delineation of privileges in order to qualify for those general funds or FRN dollars to be used towards the implementation of the team. I like that.
Yeah.
Yeah.
Here, Shell, can I just
Yes, Kim.
quickly? I just wanted to note, it looks like there are potentially members of the public that have thoughts on this particular recommendation. I just wanted to remind folks to please hold that till public comment period, which will come up in a few agenda items. There is opportunity to share that. I would just also note that if folks could please do that verbally in public comment, the chat is not as accessible to everyone on the call. For example, people calling in might not be able to see the chat. So if people could hold and share their thoughts via public comment during that period, that would ensure that everyone on the call is able to hear and see that.
Thank you for that, Kim. Okay, moving on to recommendation number 3. This is our newest recommendation. We received this in the latter part of 2025 from Chelsea Cheatham, who I mentioned a few minutes ago has now moved over to our prevention subcommittee. This is a recommendation that we have not fully vetted yet or fully explored yet. So this is, I think, a good time for all of our new members. Her recommendation was contingency management can be used to support people in recovery through rewards for reaching their recovery goals. Increasing funding to support contingency management could help more providers offer this important support program to patients. And then you'll see some of the background information there that she has noted. So just wanted to open this up for discussion. This is something that our SEI team is still workshopping for us. And we're hoping to have Chelsea. She wasn't able to be here today, and I don't believe she's going to be able to join our March meeting, but hopefully she can attend our meeting in May. But if we can find someone else to present on this next month, we will certainly do that. But I do know the SEI team is still working on this one. So what are the thoughts of our subcommittee members on this one in particular?
So Giuseppe Mandel, for the record, just if you could clarify, is it what types of rewards for like different levels of, is that what you're saying?
Yeah, that's my understanding, Kim, from Chelsea, is that there would be a
Yes.
monetary reward
Um,
for
it-
reaching
it-
different levels.
Yeah, if we could go to the next slide, I would just share that there is embedded in the PowerPoint studies, associated research that Member Cheatham had provided. So rather than speak out of turn, I would just note that these would probably be good resources to look at in lieu of when we could have somebody come and give a presentation on it, which, as the chair mentioned, we are working on identifying someone for you all to come in, hopefully March. I will just note that this information is also available on the SURG website as an attachment for this meeting. So if you aren't able to capture it off the screen, it is posted on the website in a PDF that you can access as well.
Giuseppe Mandel for the record. I mean, I do have, like, there is a company that does something similar to that could probably present, highlight like Joey's friends, AFIC. It's an online type to everything, and they give some type of monetary rewards. And then I would probably tag in somebody like maybe Dave Marlin, who helped write and put together some of the body broker and laws, which you got to keep mindful in our state too. And being that what I do for a living, there are really strict laws in place when it comes to paying for clients that are in treatment or giving them treatment. There's strict laws. And Dave Marlin is pretty well versed on them. He helped write them. And how AFIC does it. However, I know AFIC doesn't do Nevada, even though they're virtual and some of their employees are here. So, but those are two names and two things to be able to highlight. I mean, I don't think it's a bad idea. Just keep in mind that, unfortunately, some bad actors out there can ruin it for a lot of people, and hence we got the body broker laws.
Out of curiosity, with the courts, how often, how well versed are they with contingency management?
Good question. I'm not aware of that, Dr. Corona. Giuseppe, do you know?
Or is
I'm
that
not sure. I
completely
could ask, but no, I'm not sure. Like they do give, I think, like some small things like gift cards and stuff here and there. So they
Well,
do the courts. Actually, that's a good point. If you could bring in Henderson Court, maybe like Scott Carlson from Henderson Court to see how they implement their program, and you could double, kind of double edge.
I asked because contingency management kind of falls more naturally into the drug courts than it would, say, a clinic or a treatment program. The reason I say that is because there's lots of things, say, for instance, I remember hearing about a case where someone, instead of being incarcerated for a long stint, served only during the weekend, and during the weekdays, they were let out of jail to work, and were able to basically help maintain their family's income by doing so. And on the weekend, come Friday, they checked in until Sunday night. And that's something that obviously we can't control, but something that's very much in the purview of the courts. And that's a form of contingency management if you think about it. So I would say a better expenditure of funds would be to educate the courts about contingency management and how it can actually be applied in their courts rather than in our clinics, because that's where it makes a lot more sense.
And then again, Giuseppe Mandel for the record, I agree with you 100% on board with that. Just you're going to definitely need an expert on the body broker and laws, because there are very, very strict rules. Like it's got to be a certain amount, it's got to be a gift card. Like there are very strict rules on it. So in order to develop a very good plan, you're going to want somebody that's well aware of those laws. In myself, I am not an expert.
This is
I just know
one
how
we
not to
can.
break them.
Yeah. Thank you, Giuseppe.
You're welcome.
This is one that we can certainly, continue to explore. I think, Giuseppe, you brought up Dr. Marlin, Dave Marlin. I think that would be good to look at him possibly presenting to us if he's available, just to hear more about this. I think before we all decide as a body to move this on to the full surge.
I mean, Giuseppe Mandel for the record,
But
and then
yeah,
Mr. Marlin. Yeah, he's running, so any type of free press, I'm sure he'll jump on the board for it. And he's got a big heart for the
okay.
community. So, and he did help write some of those laws, and has a treatment center. So, I mean, he's pretty and worked for a major insurance company. So, I mean, he's I would say a pretty good expert on it.
Thank you, Giuseppe. So SEI will continue to help us workshop this one, and then we'll hopefully have someone lined up to possibly speak at our March meeting. And if not, at least continue our discussion on this. Okay, so on that note, we wanted to now open it up to our subcommittee members on any recommendations any of you have at this point to share with our group that we can explore and have the SEI team help us workshop.
Giuseppe Mandel for the record. Like I'm going to highlight and it's a smaller court, so that's why it would be easier to obtain. But like the Henderson Drug Court, you know what I mean? Because it's how their programs go, and figure out a way to get them fundings, whether it's through private or more grant fundings, because that's a double-edged prong. Not only did that funding help those courts and those individuals who insurance won't authorize, that money also goes back into businesses in the community, which then pay taxes. So it's an easy sell, and a big need in the community, and they've got a proven record. Um, if one of you guys can help coach me on drafting that recommendation, I'd love to.
So Giuseppe, is your recommendation to recommend that the state look at helping expand these courts through additional
Expand,
funding? Is that what?
expand these courts, and like, a lot more funding. I mean, Henderson Court got 25,000 last year. I mean, that goes nowhere. 100,000 total for the year. You know what I mean? That goes nowhere when we're talking about treatment. And with the success rates of Henderson Court, I mean, they could use more funding. And not only that, yes, that would be it. Not only that, that funding also goes right back into the community of businesses, going towards treatment that then generates more revenue and taxes. It's an easy sell, and a much needed thing. So, however, yeah, you guys could coach me on how to figure that out. I've been working with a lot of the judges recently on trying to figure out a way. We can't even get private funding into them because the regulations got to go through so many different wheelhouses. Then they got to decide where it goes, and they have a huge success rate. And you could sell it on both sides.
So Giuseppe, as part of your justification for this one, is it safe to say that the current court system is already maxed out? And so therefore we don't have as many individuals being able to benefit from that diversion into drug courts? Is that, I don't want to speak
Correct. I
for you,
mean,
but it's,
because what will happen is you're now relying on the state or grant fundings to go to lower grant funding. So they have to be very, very strategic with their funding on how they get successful treatment.
Chair Shell, this is
yes.
Mary O'Leary for the record.
Yes, Mary, thank you.
Giuseppe, if you would like assistance with wordsmithing or drafting this recommendation further, you could do the Survey Monkey that my colleague Kim will send out after this meeting, or if you would prefer to do it as a quick meeting with one of the SEI staff, we're also happy to do so. You could just shoot us an email. So however you would like assistance, we're happy to provide some.
So I appreciate that. And yes, I'll get that recommendation in, because yes, for virtual funds.
Giuseppe, I'm not sure. It may, I don't know if it's on my end. I couldn't hear the last part of what you just said. That was very jarbled. Yeah, I'm still not being able to hear you, Giuseppe. Is anyone else having that problem as well?
Yeah.
Okay. I don't know if there's something wrong with your audio, Giuseppe, or we were hearing you just fine up until about a minute ago.
Yeah, I don't know why I'm having technical difficulties here.
Okay,
Can you
that's
hear me better
better.
now?
That's better.
Yes, okay. So I put my earpods in. Yes, I mean, because the courts are short on funding, and so it limits the access of treatment that they could give, and they have high success rate. So to draft that up and make recommendations for more funding to go towards courts, um, especially since that goes back into the community and has a sustaining generator, if that makes sense, versus it's not just going on like a short-term grant process that, if something changes, it goes. I mean, it's a standing proof, and they're short on funding. They don't get enough funding.
So in terms of the funding piece, Giuseppe, I'm just thinking to myself, so we would be asking or recommending that the states allocate more funding to the counties,
Right,
possibly
which gets
through their
tricky too.
FRN
Yeah.
allocations, or
Yes, because that's the only way that it can get done. Like I
yeah,
can't even get private funding in there because it's got to go through the county and then
right.
through the whole wheel process. And so yes, I mean more funding. I mean $100,000 a year for one small drug that's nothing when we're talking about treatment. And they got
So
to
just like
choose
with our
for.
other recommendations, then it could be an allocation of general funds and or
Mhm.
the utilization of the FRN dollars.
Yes, yes,
Yeah.
and why I highlight that is especially because if we were talking about like the last recommendation of the what was it called, like monetizing and stuff like that, well then that's going to cost more money, and they're already short on funds as it is, so they're limited to a $10 Starbucks card. So it all kind of rolls into one. Does that make sense?
Yeah, that makes sense. Yes.
Let alone how much treatment costs. You know, um, the and insurance won't authorize if they're in custody for 2 weeks, even though they're not getting treatment, like Dr. Corona says. So then the courts have to step in and pay that portion of the treatment. And God, I have a big heart, but we would do it for profit. I mean, treatments cost money. It does. What I mean? Bed costs money. And I mean, God, Medicaid is still archaic at um, low rates. And when they do pay, or even commercial insurance, right? Commercial insurance won't even pay. So like there's always that 2 week gap, and that money goes fast for them.
Yeah, I like your recommendation, Giuseppe, and I'm trying to remember. I don't think there has been one in the past related to the drug courts.
There has not. Yeah, I went and
Yeah,
did
I
some
didn't think
research. There has not.
so. I do think this is a good one to certainly explore here. Dr. Corona and Dave, do you have any
I,
thoughts on this one, or are you good with us
I
I
do, and
exploring?
that's what
I'm
I
good
was.
with this one, but I do have quite a few recommendations as well, as you might have guessed.
Well, well, like I said, just I went out for the record. I mean, there's a few doctors with MDs in this meeting. So, Dr. Corona, you're right next door to us. Trust me, I'll be knocking on your door for you to help me. You got the
All
education. I
right.
just got the ideas.
All right. Well, this is a good one. I agree. Um, as far as other recommendations, well, there's the elimination of prior authorizations. That would be basically through Medicaid. Uh, for any and all medication-assisted treatment. Well, I should say treatment medications, because I don't want them to use that to get around something. Because if you leave it like that, then it makes it easier. And the justification would be that there's a narrow window of opportunity uh, to help someone enter into recovery when they're entertaining taking that step. So you want to basically strike while the iron's hot. I'm sure you can put it in a better way than I did. So that would be my my first recommendation. And if any and all treatment medications does not fly, at least buprenorphine in any and all forms. So it's already the what do you call it? The prior authorization is already eliminated for injectable, which is much more expensive. But it's not eliminated for oral, which is much cheaper. You know, answer me, give me the logic behind that. But that's currently the case. At any rate, that would be my first recommendation. Second recommendation would be to keep Medicaid from determining dosage for buprenorphine. That's really not it really shouldn't be what they should be doing, because last I checked, Medicaid and probably a lot of folks in Medicaid don't have an MD, so I'm not sure why they're deciding on the dosages. That's what people go to med school for.
Dr. Cronin, is that the case with our commercial payers as well that you're saying, or just more with Medicaid?
The commercial payers usually follow suit with whatever Medicaid and Medicare do.
Okay.
And yeah, that should be the case for all insurances, not just Medicaid. So Medicare, Medicaid, or any insurance should not be determining dosages of medication-assisted treatment. That should be the purview of the physician, because at the end of the day, we're the ones facing the patients. We're the ones that have to deal with the consequences with the patients relapsing. It's not them, so it shouldn't be them determining the dosage. And I don't know how you put that in the justification, but yeah, it's the way I see it. It's practicing medicine by committee, which never ends well. How would you guys put the justification there?
Well, I totally agree with you that I think physicians are the ones who need to be making those determinations on dosage and not non-physicians.
Yeah.
Well, and Dr. Cronin, also as part of the recommendation, do we want to add that we're recommending that the Nevada Health Authority amend their utilization guidelines or something along those lines?
Yes.
Okay.
I mean, Giuseppe Mandel, for the record, I mean, you could expand that, Dr. Cronin, to treatment in general. I mean, unfortunately, too far and too often, insurance dictates what type of treatment the patient should get rather than the MD.
Yeah, and you know what?
Understand that.
Maybe we shouldn't just say Medicaid. We should say all insurances.
Yeah, I think so.
Because yeah, it shouldn't. I mean, I'm blaming Medicaid because Medicaid's the one that came up with that rule, but it shouldn't be coming from any insurance. Yeah, that should not be in their capacity to do.
No, agreed.
And we,
I mean, an MD should be discussing that, not an insurance provider. I mean, and yes, we have more success in the commercially insured, but we still have denials, which probably an MD says they need treatment and they don't get it.
Yeah.
Yeah, I think we could certainly recommend that Nevada Health Authority look at amending their authorization guidelines, but then also working with all of those other payers. I'm not sure what that process would look like, but I think we could recommend that it be directed to them to figure out how to implement.
Okay.
We can think through that piece. But I definitely like this one.
A third one that I thought of is when patients are started on medication assisted during detox, they should not be tapered off before entering regular inpatient. Because what happens is oftentimes you see folks that come in, say, with an addiction to fentanyl, they get put on buprenorphine, but they get a very forced taper down before they go to the inpatient rehab side of things, which is just a few days later. And a big part of this is because they have this false equivalency of fentanyl and buprenorphine, which couldn't be any more wrongheaded. Because medication-assisted treatment is indicated for long-term recovery, and so should not be tapered while the patient is still in the throes of their addiction and in the nascent part of their recovery. It just doesn't make any sense. Giuseppe, how often do you see insurances pushing for this to get folks off of medication assisted treatment to get to the inpatient side?
Just Giuseppe Mandel for the record. I don't know if it's as much as an insurance as it's I don't know of too many rehabs that forcefully taper somebody off of the mat if the patient wants to be on it. I think it's more patient-centered decision on that point. And it's, half one does to the other. I mean, as you know, where my former stance was, Dr. Corona, on it.
Yeah.
I've since swayed my stance a little bit because fentanyl is killing so many people. I mean, my personal path to recovery was a short taper and and the success were being the 30-day residential, not the short taper and then right back into the community. Right, which is a huge success for failure. But some patients, I would have been one of those patients myself who would want a fast taper because I didn't want to withdraw again off the Suboxone later on. And so I don't know if it's insurance I don't know if that's an insurance thing more than a patient thing. And in my experience nowadays, the rehabs that I know, I know they let the patient kind of decide if they want to do that or not. And I don't think we have a hard time that I know of with getting authorized if they want to stay on that. Sometimes the patient just doesn't want to stay on that. And it's about 50-50.
Well, one thing is getting off of medication assisted treatment upon discharge from the inpatient setting, but it's another thing completely tapering them between detox and the inpatient side, because between detox and the inpatient side, you're talking maybe a few days. Whereas
and
from
see
detox to discharge, you're talking more likely a month. So
I don't think I see an issue with that with insurance authorizations or treatments. Where you do see issues out of is and most of the sober livings have come around is sober livings that don't want to accept somebody on MAT treatment. And so then they would have to. I don't necessarily see the treatment. I mean, it's kind of 50-50. If the patient is, if the doctor suggests it and the patient wants to stay on it, some of the patients don't. I don't think we have a hard time getting authorization on that. But I could be wrong too, Dr. Corona. You work more in that end than I do.
Okay.
It'd be definitely a conversation you'd want to have with maybe Dr. Kaplan who oversees a few of the treatment centers. You know, he could probably give you a better idea of that.
Fair enough. But actually, Giuseppe, you just brought up another good point, is the barring of folks that are on medication-assisted treatment from sober livings.
And some want it, some don't. That's kind of one of those things. It's a private entity, you know what I mean? So like it's hard to go and tell like a guy who runs an Alcoholics Anonymous house, like let's just say right for alcoholics, hey, you have to accept God in that treatment if his program is successful the way he does it. Some do, you know, but I don't think we're having a hard time anymore. It was at first, but I don't think we're having a hard time anymore placing patients with sober livings that accept it, and then some just don't. You know what I mean? And it's. I don't think aggressively going in telling them they have to do it is any help either. You
Well,
know,
should they be receiving funding though if they don't?
well, so most of them don't receive funding. I don't know too many of them that do. I mean, most of them, you're going in sober living, at least in Nevada. There's no funding for sober living for most of them. The ones that do probably do, and I mean, those ones aren't as successful either, to be honest with you. Most of those sober livings are people in recovery, and they don't do it to get rich. You know, they might have 3 or 4 houses, and you know,
Yeah.
they make just as much as if you would rent it out, maybe a little bit more, considering the cost of it. But no, I mean, if you're talking about like NBH or one of them that have housing, or like Desert Hope has like housing, but even the patient still has to pay for it. They don't get funding for that. Um, they allow Matt. The only ones that I think get funding for treatment would be like NBH, which is doing that for a little while, where if you did their program, they could help pay for your sober living or something. But I don't think that there's funds out there really for housing participants, unless like Pat Coalition might do like a barrier removal gap for one case by case basis or something. But there's not really funding that does mass amounts of sober living that I know of.
Yeah, it's just, I mean, if you really think of it, barring Matt from a sober living is a violation of the ADA.
50-50, man. Dangerous territories, right? Like, do you really want to go and enforce guys that have had sober livings for 30 years that have helped thousands of guys and tell them they got to change the way they do it, even if they're not getting funding, if it's their own entity? You know, I mean, it's
Yeah.
that's a slippery slope. You know, I could understand if it was like a program that they were getting funding and stuff, but at the same time, I mean, it's their business, and that's a tough business. You know what I mean? So
No,
we can't really go in and
you're
tell them how
right.
they
You're
have to
right.
do it.
It is a tough business, and it is as it is. We don't have enough sober livings, but I would at
Yeah.
the very least make it a requirement that if they're going to see funds, that they accept folks that are on MAT. I think that's fair.
Yeah, I mean, I have no debate either way on that, because we always have the ones that aren't going to receive funds that'll do
Yeah.
it their way. So, I mean, I have no debate on that either way. You just want to be careful mandating, like if there is a mandated where you have to enter a certain license to have a sober living, and then you mandate that person to have to accept Matt. I mean, you're kind of messing with the experts in that area. Then, you know, if they've successfully done it for 30 years and have had multiple houses, like we don't necessarily want to take those houses away because we can't afford to. Does that make sense?
Yeah, but I'm just saying that, you know, if they're gonna be receiving funds, then they should have to attend to both types of patients that are on MAT and patients that aren't on MAT.
And that would where I would suggest getting a committee of sober living owners and discussing it with them. You know what I mean? Seeing what their input is in the
So
community, because
Yeah.
we don't have a
No,
ton of people that
that's
are
fair.
jumping
That's
in to
fair.
get sober livings. You know, I mean,
That's
not
fair.
a lot of people want to put their property up for a sober living. It's
Yeah.
a tough job. It's a tough
so
job, and you don't get rich doing it.
So everyone, I hate to have to conclude item number 5, but we've only got 5 minutes left in our meeting today, and we've got a couple more agenda items to get through. But I really appreciate the great discussion we've had on these new recommendations today. If you have any other recommendations to make before our next meeting, certainly work with the SEI team between now and then, and they will help you put together the recommendation and get that on our next meeting agenda. But again, thank you all for that great discussion. So item number 6 is discussion only. This is a discussion regarding topics of interest from our subcommittee. And I think it's the one that I'm about to mention has been very pertinent to our discussion today. We had someone via public comment in the prevention subcommittee meeting back in November bring up the difficulties that are faced out in the rural areas regarding accessing MAP prescriptions. So I think everything you brought up today, Dr. Corona, has been extremely helpful regarding particularly this topic of interest. And we can get into that more in our next meeting in March. But just wanted to mention that was brought up in the prevention subcommittee meeting in November. And we all know that the rural areas have lots of challenges, and I think we could certainly discuss more about that in March. Moving on to item number 7. This is for public comment, discussion only. I will turn it over to Mary just to walk us through that process and see if we have anyone wishing to make public comment.
Thank you, Chair. Mary O'Leary for the record. Public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during this agenda item until the matter itself has been specifically included on an agenda as an item upon which action may be taken per NRS 241-021. If you are dialing in from a phone, dial 669-900-6833. When prompted, enter the meeting ID 865-8016-1096. Please press *6 so that the host can prompt you to unmute. Members of the public are requested to refrain from commenting outside of the designated public comment periods unless specifically called upon by the chair. Chair Estrell, I see a couple of hands opened or hands up. So
okay, thank you, Mary. I just will remind everyone that we only have a couple of minutes left, so if everyone could keep your comments brief, we would greatly appreciate it. I see Jess Angel with her hand raised first.
Hi, Jess Angel, member of the public for record. I just wanted to comment on your second recommendation about peer support being in hospitals. I do have to agree a lot with Dr. Corona. So I'm newly here to Nevada from Alaska. And in Alaska, we had a process called a variance process that allowed those with different barrier background crimes to work in like the healthcare or social work or any kind of like with children, things like that, the youth. It worked very well. I noticed that the state of the state of Nevada does not have a variance process. And I want everybody here to keep in mind that a lot of those who are peer support, some of them cannot pass a background check. So if that's something that's wanting to be brought into the hospitals, that is going to be a barrier for people to get in, is they're not going to be able to pass that background check. So I think maybe to add to that recommendation would probably be smart to try to look into what maybe a variance process would look like. And just briefly, because I know other people have their hand up and want to comment as well, is for instance, like in Alaska, it would basically be like, you know, if they had passed their probation, if they had been sober for so long, went through a treatment, they would get like character references. They would have people, you know, just different documentation that they could get together. It was a packet. It was a pretty thick packet of paperwork that people would have to fill out. But with the proper support in place, I was able to get these people into these positions where we actually truly, really need them. So thank you for your time.
Thank you, Ms. Angel. Next, I see Lauren Beal with her hand raised.
Hi, Lauren Beal for the record. I just wanted to, in that last conversation, something came up that's been a big conversation happening up north around sober living homes not having any sort of framework or guidance, and how that has created spaces where people are having reoccurrences that are now becoming kind of not helpful. They are no longer serving the purpose of being a sober home. And I think that there is room for this committee to think through what sober homes should have in them. And there are people in this committee who are experts on the topic. And I think that that's a really good space for us to kind of continue to think through, particularly as we are seeing concerning things happening.
Thank you so much for bringing that up, Ms. Beal. Next, I see Marcy Trier.
Yes, hello, DCFS, Marcy Trier. For the record, I would just like to comment that as a suicide crisis responder, where I responded to all the hospitals across Las Vegas for the past 6 years for children's mobile crisis, I will say the idea of the peer support specialist is very good. However, I think that some of the barriers you'll run into, myself going into all the hospitals to do suicide calls for basically people 21 and younger. There's, the issue of confidentiality, HIPAA, trying to get the clearance, as Jess was just speaking on. And also that the peer support specialists are very specially trained in suicide because there's such a correlation between substance abuse, addiction, and suicide and overdose. And so I think that going into the hospitals, you really have to have a specialization, as the doctor did really go into, because this is, the doctors are going to be very leery. Like for myself going in, they were very used to me and they were very comfortable. But I think that just due to, the caution of going into the hospitals and also the patients may be tentative as well, if they don't have like a specific role. I just think that's something, just because of my own hands-on experience of going into all the hospitals overnight, all night long. It's just something thing that, while the idea is really good and it's so important in recovery or in the immediate stages of like overdose, to have that peer support, but they have to have that special training to understand, I think, suicide and addiction and of course, yeah, they are probably have that experience themselves. But there's also the book knowledge that they need to have, as well as the experiential knowledge. And that's all.
Thank you so much, Ms. Trier. And next, I see Beth Scott.
Thank you, Chair Shell. The Beth Scott with Nevada Medicaid for the record. Jumping onto the peer support bandwagon, I would ask that you please invite Medicaid to any discussions about what are the barriers to implementing the peers into the emergency rooms. I know that we're currently working on a lot of work with the peer recovery support specialist services. So maybe there's something where we can come together and figure this out. But I think for me, first of all, I would need to know what those barriers are. But admittedly, I might not be the best person on the team to have there. So I just ask for an invitation. And then secondly, to help with some language, particularly as Giuseppe and Dr. Corona were talking about medication-assisted treatment and Medicaid. Medication-assisted treatment is kind of like the umbrella that includes medications and therapy. But it sounded like, just for clarification, Dr. Partita, were you talking, or Dr. Corona, were you talking about medications for opioid use disorder when you were referencing Matt being like during detox and not being tapered?
Yeah, particularly buprenorphine.
Okay, I just wanted the clarification on the record. Thank you so much.
No problem.
Great. Thank you so much for bringing that up, Ms. Scott. And do you see anyone else, Mary, wishing to make public comment? I don't see anyone.
Mary Lear for the record. I also do not see anyone.
Okay, thank you. That will conclude public comment. Our last item is adjournment. We thank you all again for being here today. This was a great discussion, and I'm looking forward to our subsequent meetings, and we'll see everyone in March. Have a great day, and thank you again.
Have a good day, guys.
Thank you.